Thank you so much for joining us, Dr. McNalley. I'll let you go ahead and make your introduction since you're on. Good to see you.
Thank you so much. And I'm really regretting that in my biography, I didn't mention that I went to medical school at the University of Iowa, where Ms. Trout is speaking from. So it's an opportunity to at least say, go Hawkeyes.
Go Hawks! Go Hawks!
Go Hawks, yeah. I was thinking about the wave and what a beautiful tradition that is. And those of you who may not know that at the end of the first quarter of every Iowa home football game, all the folks in the stands, the 60,000 folks and the players on both teams, the referees all turn and wave at the kids who are up in the hospital, Instead Hospital in Iowa. It's a really lovely tradition that they've started. I am very pleased to be here with you all. Thank you so much for including me today and giving me the opportunity to talk about Duchenne Muscular Dystrophy and palliative care. There we go. I do not have any disclosures. I should say that in the past, I was a funded participant in the Teplerson studies when I was at Seattle Children's Hospital. I am no longer involved in that and haven't been for 4 years. So it's not, I don't think it's relevant for this particular presentation as well. So I'm going to ask you all, it's difficult to have an interactive session on Zoom. In this new reality that we're all facing, where almost all of our presentations are online. But I'm going to ask you to answer this question if you don't mind. Just take a couple moments, and if you don't know, I'm happy to have you say I don't know. But if you have a sense of what palliative care is, are you willing to write just a few notes into the chat box that we could all look at together, and then we'll talk about it together as a group. What's your definition? What's your sense of what palliative care is? Thank you, Tiffany. Maintaining quality of life. I like that answer a lot. Thank you for that last comment about not being the step before hospice. Great. Sorry about your father's death. I'm glad it was a loving experience. And thank you to Allison Judge for pointing out the importance of emotions in this work. So please feel free to keep on adding if you'd like. I'm going to give you a couple definitions and then kind of go through over the next few slides my own approach and the way we do things at UC San Francisco. So the WHO definition of palliative care is an approach that improves quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by early identification, impeccable assessment, and treatment of pain and other problems, physical, psychological, and spiritual. And they give a long list, which I bulleted out for you here. I don't want to read through each of these individually, but if you sort of scan, you'll see again, symptom management, views about dying. I think it's very important to look at number 3. Folks often associate palliative care with death, with end of life, and that is certainly a part of what we do. But it's really important to emphasize that we are not in the business of hastening or postponing death. We're in the business of aligning a dying process with the values of the person and the family involved, if that is what they are facing at that time. We should always be thinking about the psychological and spiritual aspects of care. We offer a support system for patients and families. And as a couple of you wrote in the chat boxes, this is about quality of life. My own training is in physical medicine and rehabilitation, and that's also as well as in palliative care. And that's also an important part of what we do in rehab medicine. That is, we're thinking about quality of life. And I like the expression, we're adding life to years. Not just years to life, but life to years. So when I talk to families, it's difficult to read to them 2 slides like I just showed you. And so I will often talk about us being an extra layer of support. The word palliate means to cloak or to wrap around. And I think about the child in the center and the family around them and then the medical team. And we're another layer of support that weaves through those to help people feel connected, supported, and understood. One of the other things I think we do is we are good at managing and tolerating uncertainty. And with conditions like Duchenne dystrophy, there can be a lot of uncertainty that arises, and it can be troubling. It can be troubling, honestly, not only for kids and families, but also for the medical providers. And a part of our job is to hold that uncertainty and to normalize it, and to, again, draw out the things that are of importance for the kids and families at the center of this experience. And then we are a team that looks at the whole person to help minimize suffering. We attend to physical, emotional, spiritual, and social needs. And it's very important for me to let families know that we're going to accompany them through their illness, that we will be by their side, whatever they face. This is an image that you may have seen before from the Lancet article. And you see on the bottom right, the psychosocial management includes a number of different areas, certainly in the diagnostic area, the top left, genetic counseling and family support, but also symptom management. A number of areas are things that we're going to be thinking about as well. And again, all to support quality of life. So why palliative care in Duchenne dystrophy? It may seem obvious or maybe not. And I have a number of areas here that I'm going to go through in my next 20 minutes or so. I'm going to start, first of all, about talking about communication, quality of life, and eliciting goals and wishes. And we'll come back to those other bullet points in a little bit. So who's part of the palliative care team? And when I was a kid, I used to love comic books, and I used to love watching the Justice League of America on Saturday mornings. And I think one of the reasons I like those shows, sort of like the Avengers, I like the idea of different skills coming to save situations. So you've got Superman and Wonder Woman, and I can't recognize everybody else on the picture. I think Green Lantern is on there as well. And I don't actually ascribe to the idea of healthcare workers being heroes, but I do think that we do wonderful work, and I'm proud of the work we do. And I'm proud of the fact that within a palliative care team, we can draw on the expertise of a number of different folks. So nurses have particular training and eye to patient experience that I don't have. And same with a social worker, a chaplain, or a pharmacist. And we can each bring our skills to a comprehensive look at a child and their family to help support them. We work together in that way, and you'll find, whether you're in an outpatient or an inpatient setting, the palliative care team may consist of a few members. You may have a physician. Some folks do not have a physician, particularly in some pediatric hospitals, because there's pediatric palliative care is relatively new, so not every children's hospital has a pediatric palliative care physician. Often there will be a nurse, a social worker, chaplain, or a pharmacist, and it may be some subset of that. It's rare to have everybody together on the team. I will say at UCSF, where I work, we're also very fortunate to have a dedicated grief counselor. We have an acutherapist, a person who does both acupuncture and acupressure. We have massage therapy, aromatherapy as well. So we have a nice group of integrative medicine providers as well, which again, I didn't put on this list because I don't think it's universal. I also want to talk a little bit about multi and transdisciplinary care. So in transdisciplinary care, team members have some abilities in other areas. For example, I do have some ability to do a spiritual history. I can ask people about their spiritual beliefs, and I can do some elicitation. I can intervene a little bit in that. I can certainly do a little bit of social work. And I also would expect the other members of my team to be able to do some of the work that I can do in terms of asking about symptoms. And that is, I think, a strength of our team, in that we can complement and augment the work that one another does. A multidisciplinary team more strictly would be just fulfilling one's roles, but not necessarily taking over the role of someone else. So to go back to the Justice League of America or Avengers, the idea is that I might have Wonder Woman's, she has her lasso, I think she uses as well, or Green Lantern's ring, and maybe Wonder Woman would have the ability, like Superman, to do X-ray vision or something like that. So try not to overuse that metaphor. So if you're in a palliative care visit, what happens? And I imagine some of you have been in visits with palliative care teams. My goal is always to listen and to listen and to listen. And it's ironic that I'm giving you a talk in which I'm mostly talking and you're listening to me. But if you were to come and see me, my goal would be to listen in a particular way. I try to adhere to what I call the 90-10 rule, which is that 90% of the time the family or the patient should be speaking and 10% of the time I should be speaking. So I should be listening. And I try also, I aspire to what I have learned the term called generous listening. And by generous listening, that's a listening that lets go of any agenda that I might have, any judgment or any imposition of a medical or other narrative, and just allows the story of a patient and a family to unfold in front of me. And so my job as a palliative care physician is to listen with my heart and listen with my mind, and to allow a full narrative to unfold. Some specific things I may ask about during my 10% of the time that I'm talking is asking specifically about how do you see your condition? How do you think things are going? Sometimes we'll ask, what is your child up against, or what are you up against with your condition right now? How do you see your situation? I'm very interested in coping and resilience, and so I'll ask about that, and also about where strength arises for each person. It's critical to know who the important people are in one's life, and then in talking about quality of life, sometimes you can ask more generally, and folks are really very facile with this. And what does quality of life mean for you? Sometimes that can be a little bit opaque, a little bit hard to express. And so I may start with another question like, what's a good day like for you? And what's a bad day like? And as you reach a point of a condition that's progressing and you're having a lot more bad days than good days, they might start thinking a little bit differently about what the goals of care and intervention are. And so that can be a guideline for us. I just take a minute here and talk a little bit about coping and resilience, and a model that I find very effective in thinking about this that was developed. I'm sorry, I can't remember this first person who developed. I know it's been also worked on by a team up in Seattle that does work in the cancer patients. And it says that really our resilience is kind of a three-part thing. There's the center part, which is who we are as people, as each of us as an individual. So what are our attributes that give us that grit, that bounce back, that ability to be resilient? Could it be our intelligence, our sense of humor, our emotional availability? Could it be just our intensity? It could be a lot of different things. What are those qualities that each of us possesses an individual that help us be resilient? The next level past the individual is interpersonal, community, family. So who are the people around you that support you? And that can be, of course, your immediate family, but also friends. It can be extended family. It can be your school or work environment. It can be your healthcare team. There can be a lot of people who are those connectors with you, or people who are connected to you. And then the final level that we talk about is spiritual or existential. And how do you make sense out of what your life experience is? These are questions that we all ask ourselves. What does my life mean? How am I going to make sense of it? And how do you make sense of it in the context of either having Duchenne dystrophy or being a family member of someone with Duchenne dystrophy? We often ask about hopes and second hopes. Sometimes in medical thinking, we'll talk about goals of care. And again, goals of care can be a little bit difficult for folks to articulate particularly in the moment. If I just ask you right now, what are your goals? Sometimes a little bit more helpful to talk about hopes. And I actually invite you at this moment to just take a minute and think about hopes for yourself. What are the things that you're hoping for, even in the next little while during the Embrace the Moment webinar or this week, this month, and sit with those a little bit. And sometimes it's helpful to write those things down and see how they evolve. It's a little bit like gratitude practice, which I'm sure many of you are familiar with, the idea of writing down things you're grateful for each day, and also the aspirations of hopes. The idea of second hopes is an important one in the palliative care world, and this is when, for example, I mean, say if I'm talking to a patient who has cancer and their cancer is quite advanced, let's say it's an adult, and I ask them, what are you hoping for? And they say, well, I'm hoping for a miracle, and I'm hoping that I'll be cured. And of course, I share that hope with them. I want them a miracle or a cure. I also want to consider the possibility that that might not be the case. And so if that's not possible, what else might you be hoping for? And that's what I refer to as second hopes. So that fundamental hope of cure, of continuing to live, we all hold very deeply. And secondarily, what other things are we hoping for? We'll also ask about worries, concerns, fears. What are the things that keep you awake, that keep you preoccupied? What is the things that might be scary about the disease or this condition? And the other things that may come up during our time is, what other experiences with serious illness have you had? I'll share with you briefly that when my father died 20 years ago, I was at his bedside. That story is a very important one in the way I think about care and the way I think about my own life, and it forms who I am. And those powerful experiences are helpful for us to understand for our patients and their families. And we also ask about what level of medical intervention are you willing to tolerate. And in Ms. Trout's talk before, she talked about advanced directives and care planning. And these are the kinds of questions we may ask related to that. Are you willing to tolerate cardiopulmonary resuscitation? Does it make sense for you given your medical condition? Other uses of medical technology, not just use of a ventilator or tracheostomy, but feeding tubes or other kinds of sort of medical, even IVs and fluids or antibiotics that may be part of the interventions offered in a medical setting. So what we'll talk about as well is your preferences in terms of communication. Some people like to have a big picture view. Some people like to have a lot of very specific information given to them. We'll see this often. It'll be different between parents. One parent may wish to be very specifically updated at all times. Another one might want to just get information sort of in clumps every few days. And both of those are fine, and both of those are very adaptive and appropriate. It's helpful for us to know so that you're not in one sense, either place, getting underinformed or overinformed and overwhelmed. And then in terms of this may come back to coping as well, but planning preferences. Some people prefer to take things as they come and kind of react. I have a colleague who liked to use the expression earthquake kits, and those of us in California know about this, that we know that we're at risk of having an earthquake and having something really disruptive happen in our lives. Some people like to have a kit in their garage or in their car, and we encourage people to do this. It says, you know, you're prepared for this, this moment. And similarly, using that metaphor for someone with a serious illness, what are the things that you want to have in your earthquake kit if your child should have a significant change and deterioration in their health status? And of course, we always want to both start and end with any other concerns that you may have. Finally, we're going to connect you with resources. I rely very much and admire the work of social workers in smoothing the path for folks in the world outside of the hospital as they navigate through their days. We want to use your goals and your wishes to guide this plan of resources. What are the things that matter for you? So in the Bay Area, we have a number of resources that can be helpful for folks through our Regional Center and CCS, which are both state programs, but also the Bay Area Outdoor Recreation Program, which is a wonderful way for folks to be involved with certain kinds of physical activities, and camps, et cetera, that may be important and really a source of a lot of joy and excitement for kids. Similarly, Cure Duchenne, other organizations may be supporting and then support within other neuromuscular clinics. So we'll be working as part of the palliative care team to make sure that we're getting you that support. And again, coming back to Ms. Trout's earlier comments, we are tasked with advocating within the healthcare system to support you and make sure, again, your goals are in alignment with, and the interventions are in alignment with what your goals are. So we take your hopes and worries and we talk about those in terms of goals. Sometimes it's helpful to have someone within the system to be a spokesperson in difficult conversations. And so if it's a point where, again, there's been a change in medical status, you have the primary neurologist or a physiatrist, a cardiologist, pulmonologist, and family, and we're all talking together. Sometimes it's good to have someone in the room who can help articulate the things that are important for you. Our goal is also to be a safe place to bring concerns. And sometimes it can be difficult to raise doubts, questions with your primary physician because of worries about letting them down, or a sense of you don't want to express that you might be giving up in some way. That those relationships can be a little bit tender. And so we want to be a safe place for you to bring any of your questions. And then finally, the idea of a POLST form, there are different titles for this in different states. Physician's orders for life-sustaining treatment. These are orders that we can help you put together, decide on what they're appropriate for. And in California, it's a pink 8.5 by 11 sheet that will say specifically this person does not want cardiopulmonary resuscitation or may want cardiopulmonary resuscitation, but not some other interventions. Usually it's full interventions, limited interventions, or comfort focus only. And we'll go through the form with you and talk about what makes sense, again, given the goals and desires that your family may have. As Ms. Trout mentioned, I don't have a bullet point for this. We can also work on advanced directives and specifically identifying caregivers and spokespersons, surrogates for decision making as well. And that can be entered into the medical record to be available for any hospitalizations, admissions to the healthcare system. So we have a little bit of time to talk about symptom management here. And I want to just spend some slides talking about that. So a lot of people worry about physical discomfort at the end of life or as a disease or condition progresses. And we have particular training in managing those things. Each of these could be an hour-long talk in and of themselves. So I'm going to be doing a fairly brief scan of these 4 issues, and these are not a comprehensive list of issues that could come up. But I want to at least talk about them and mention that they are available for things for us to talk about. So pain in Duchenne dystrophy, I know a lot of the folks either who are listening or family members with Duchenne dystrophy know that musculoskeletal pain, back and hip pain can be really quite significant. Muscle tightness can be problematic. There can be pain related to constipation or just slow transit or reflux. And then headache, which can come from having insufficient ventilation or from neck pain that's transmitted to the head. And we have a number of options that we can use to address that: positioning, different equipment, massage, as I mentioned, acupuncture, acupressure can be helpful in some cases, medications, of course, education, and some relaxation techniques. And again, this is not a comprehensive list, but want you to know that we're thinking about it and that there are things that we can do to help. Similarly, shortness of breath is an area that's often a concern for folks as their medical conditions progress. Non-invasive ventilation like CPAP and BiPAP certainly can be helpful for this. Supplemental oxygen can reduce that sense of air hunger. There's been some interesting studies that a fan directed onto the face may reduce that sense of shortness of breath. We actually have sensors in our face that respond positively to that sense of air being blown across us. And I think we all know this intuitively. If you've been sitting in a building inside for a number of hours and you step outside and you feel that rush of air go across your face, that's a really wonderful sensation. Actually, it's a sort of inherently soothing sensation. And we've found that directing air directly onto the face can reduce that sense of shortness of breath, and it's the same sensors. Just a caveat to this, some people don't like this, and so, or it's important not to make too much, not have the fan be at too high speed. And then positioning can certainly help with shortness of breath, especially rolling to one side or the other to get a lung that is more inflated or more aerated up where it can be more accessible. So if a person is having significant shortness of breath that is not managed with the above interventions, then we do have some medications. And opioids like morphine can be used to help reduce the sense of shortness of breath. We usually use them at a lower dose than for pain, and it's usually about 50% of that dosing for pain. The research is very good that this does not hasten death if it's used in response to symptoms alone. So if you're following the symptoms of shortness of breath and use the medications in that way, it will not speed up death. To be perfectly frank, you can use opioids to hasten death, but that's illegal and wrong. And so we don't do that. But if you, again, use these medications to respond to symptoms, then they can reduce the sense of air hunger. And then if someone really has a lot of anxiety, and that's the more predominant symptom rather than true sort of respiratory drive of shortness of breath, we'll sometimes use medicines like diazepam, lorazepam, and midazolam. Those are more commonly known as Valium, Ativan, and Versed. If that's the predominant symptom is truly anxiety. In general, we don't like to use opioids and benzodiazepines together. Constipation, in my experience, taking care of boys and young men with Duchenne dystrophy can be a big problem and cause a lot of suffering, a lot of discomfort. And this is common because of reduced physical movement, because the intestines over time tend to slow down. Medications and diet can both contribute to this as well. So movement within the restrictions, of course, of having Duchenne dystrophy. Changing diet, a lot of fiber, a lot of liquid, medications, stool softeners, and sometimes using medications that stimulate the bowel to move. And then in more severe cases, we can use suppositories or enemas to address this. I have a colleague here at University at UC San Francisco who likes to talk about mush and push, meaning that you want to soften the stool, but also give something that sort of helps the stool move along. And those are the ways that we think about helping with this particular problem. The panda here is to represent the opposite of agitation and anxiety. For folks who are feeling this, we want to talk about psychological, emotional support, teach self-soothing techniques, including invoking meditation or prayer, those things that can help center us back in a calmer space. And we know actually that some of those breathing exercises and meditation exercises can trigger the parasympathetic nervous system, which is the resting anti-stress side, and it will dampen down the sympathetic system. We also have medications that can help with that, sleep medications as well as benzodiazepines that can contribute. So as we continue to integrate palliative care into Duchenne dystrophy care, you'll be seeing this more in neuromuscular clinics, and more connections to state support agencies is something I'd like to see. And I would also hope that we'll be able to make early connections with families to develop long-term relationships and to accompany patients through the course of their condition. And in summary, I'd like to say that our palliative care encompasses many aspects and domains of care of the whole person. And that's why we involve so many different specialists to think globally about the individual and the family. We focus on quality of life, reducing the burden of disease. The emphasis is on care wherever the patient is in their course. And sometimes we'll say care over cure. Not that we are against cure, but that our focus is on care. Meticulous and comprehensive symptom management and alignment of goals, hopes, values with medical care. And I thank you very much for your attention.